Moving on to chapter 26 of Katzung and Trevor's board reviews, we'll discuss local anesthetics in this chapter. So, local anesthesia results when sensory transmission from a local area of the body to the CNS is blocked. So, you have the brain, okay, and the spinal cord, okay, alright. So, this includes the CNS, the brain, and the spinal cord. So, when the sensory transmission, so let's say, for example, sensory transmission from your local area, from a local area of a body, of the body to the CNS is blocked, then local anesthesia results. The local anesthetics constitute a group of chemically similar agents, esters and amides, that block the sodium channels of excitable membranes. So, excitable membranes, okay, so it's a bilayer, right? Phospholipid bilayer. So they have certain sodium channels, okay, and these esters and amides, they block these sodium channels. So because these drugs can be administered by injection in the target area or by topical application in some cases, the anesthetic effect can be restricted to the localized area such as the cornea or an arm. When given intravenously, local anesthetics have effects on other tissues such as the heart. So coming to the classification of local anesthetics, so we can divide them into two groups based on the chemical structure. They can either be esters or amides. So coming to esters, we can again divide them on the basis of their action. So duration of action, we have long acting esters such as tetracaine, okay, tetra. So tetra means 4, right? So 4 is kind of a big number, okay, from 1 to 5. So it is a long acting ester. Whereas short action, you have procaine. It's a pro, okay, it does its job quickly, so it's a short acting ester. And then surface action, we have benzocaine and cocaine, okay, they are surface acting local anesthetics. What are they? Benzocaine and cocaine. So coming to amides, again we have long action and medium action amides. So long action, we have bupivacaine and ropivacaine. So butyryl is like 4, right? So bup, so that is also a long acting thing. And also rope, a rope is a long thing, right? So ropivacaine. And then medium action, we have lidocaine. Alright. So coming to the chemistry, most local anesthetic drugs are esters or amides of simple benzene derivatives. So subgroups within the local anesthetics are based on this chemical characteristic and on duration of action. The commonly used local anesthetics are weak bases with at least one ionizable amine function that can become charged through the gain of a proton. So the commonly used local anesthetics are weak bases with at least one ionizable amine function. Okay, so they all have a benzene derivative, right? They're all benzene derivatives, so they have a benzene name. Okay, something, and they have at least one ionizable amine function. Okay, so this amine function can gain a proton. Okay, it can gain a proton and become charged. Okay, so as discussed in chapter 1, the degree of ionization is the function of the pK of the drug and the pH of the medium. Because the pH of tissue may differ from the physiological 7.4, it may be as low as 6.4 in infected tissue, the degree of ionization of the drug will vary. Because the pK of most local anesthetics is between 8 and 9, they're weak bases, right? So they have to be above 7. Benzocaine is an exception. Variations in pH associated with infection can have significant effects on the proportion of ionized to non-ionized drugs. So coming to the pharmacokinetics, many shorter acting local anesthetics are readily absorbed into the blood from the injection site after administration. So if you inject a drug, okay, so they're rapidly absorbed into the blood. The duration of local action is therefore limited unless blood flow to the area is reduced. So how can you reduce the blood flow to that area? By administering a vasoconstrictor, usually an alpha agonist sympathomimetic with the local anesthetic agent. So cocaine is an important exception because it has intrinsic sympathomimetic action due to its inhibition of norepinephrine reuptake into nerve terminals. So cocaine is an exception because it has intrinsic sympathomimetic action due to its inhibition of norepinephrine reuptake into nerve terminals. So the longer acting agents such as bupivacaine, ropivacaine, which are amides, and tetracaine, which is an ester, so they are also less dependent on the co-administration of vasoconstrictors. Because they can act for a long period of time, they do not readily enter the bloodstream, so you do not need to co-administer a vasoconstrictor agent. Surface activity, that is ability to reach the superficial nerves when applied to the surface of mucous membranes, is a property of certain local anesthetics, especially cocaine and benzocaine, both only available as topical forms, lidocaine and tetracaine. Metabolism of ester local anesthetics is carried out by plasma cholinesterases or pseudocholinesterases and is very rapid for procaine. Okay, so procaine is a pro, it does its job quickly, so it's a short acting ester. So half life is only 1 to 2 minutes. It is slower for cocaine and very slow for tetracaine, that is why it is long acting. The amides are metabolized in the liver in part by cytochrome P450 isozymes. The half lives of lidocaine and prilocaine are approximately 1.5 hours. So 1.5 minutes in the case of procaine to 1.5 hours in the case of lidocaine and prilocaine. Lidocaine is a medium acting drug, okay? So bupivacaine and ropivacaine are the longest acting amide local anesthetics with half-lives of 3.5 and 4.2 hours respectively. So which one has the longest half-life? Ropivacaine. Rope. Okay, rope is quite long. Liver dysfunction may increase the elimination half-life of amide local anesthetics and increase the risk of toxicity. So, acidification of the urine promotes ionization of local anesthetics. The charged forms of such drugs are more rapidly excreted than non-ionized forms because most local anesthetics are weak bases. So, acidification of the urine promotes their ionization and hence excretion. Coming to the mechanism of action, local anesthetics block the voltage dependent sodium channels and reduce the influx of sodium ions, thereby preventing depolarization of the membrane and blocking conduction of the action potential. So what they do is they prevent the influx of sodium ions by blocking the voltage dependent sodium channels, and they prevent depolarization of the membrane. Local anesthetics gain access to the receptors from the cytoplasm or the membrane, as you can see in this figure. So this is a schematic diagram of the sodium channel in an excitable membrane such as an axon and the pathways by which a local anesthetic molecule or drug may reach its receptor. Alright. So sodium ions are not able to pass through the channel when the drug is bound to the receptor. So when the drug is bound to the receptor, sodium ions are unable to pass through the channel. Okay. So the local anesthetic diffuses within the membrane in its uncharged form. So in its uncharged form, it diffuses within the membrane, okay, as you can see here. In the aqueous extracellular and intracellular spaces, the charged form is also present. So in the intracellular space, okay, this is intracellular space, it is present in the charged form. You can see the plus sign here, alright. And also in the extracellular space, it is present in the charged form. You can see the plus. Because the drug molecule must cross the lipid membrane to reach the cytoplasm, the more lipid soluble, that is the non-ionized uncharged form, reaches effective intracellular concentrations more rapidly than does the ionized form. Okay. On the other hand, once inside the axon, the ionized form of the drug is the more effective blocking entity. Thus, both the non-ionized and the ionized forms of the drug play important roles. First in reaching the receptor site and the second in causing the effect. Okay. So, the non-ionized form reaches the receptor site. Okay, as you can see here, the non-ionized form reaches the receptor site. Alright. And then the ionized form carries out the blocking effect. So the affinity of the receptor site within the sodium channel for the local anesthetic is the function of the state of the channel, whether it is resting, open or inactivated, and therefore follows the same rules of use dependence and voltage dependence that were described for the sodium channel blocking antiarrhythmic drugs. So in particular, if other factors are equal, rapidly firing fibers are usually blocked before slowly firing fibers. High concentrations of extracellular K plus may enhance local anesthetic activity, whereas elevated extracellular Ca plus 2 may antagonize it. Coming to the pharmacological effects, so nerves. Differential sensitivity of various types of nerve fibers to local anesthetics depends on the fiber diameter, myelination, physiological firing rate, and anatomical location. based on this table right here. Okay, so type A type A alpha fibers are less sensitive to be blocked because they are heavily myelinated, and the conduction velocity is the greatest, and the diameter is also quite large. Okay, coming to beta fibers, they are also quite heavily myelinated. All the type A fibers are heavily myelinated, and the diameter is, it keeps decreasing as we progress from alpha to delta. So the conduction velocity also keeps decreasing, and the sensitivity to blockage keeps increasing. Coming to type B fibers, their myelination is not as heavy as type A fibers, and the conduction velocity is also less, so the sensitivity to blockade is more. Coming to type C fibers, uh, again the sensitivity to blockade is quite more because there is literally zero myelination of the type C fibers, both dorsal root and the sympathetic fibers. Okay, so in general, smaller fibers are blocked more easily than larger fibers, and myelinated fibers are blocked more easily than unmyelinated fibers. So that is what is shown here. So unactivated pain fibers fire rapidly. Thus, pain sensation appears to be selectively blocked by local anesthetics because they fire rapidly. Fibers located in the periphery of a thick nerve bundle are blocked sooner than those in the core because they are exposed earlier to higher concentrations of the anesthetic. Coming to other tissues, the effects of these drugs on the heart, we've discussed that again before. So, most local anesthetics also have weak blocking effects on skeletal muscle neuromuscular transmission, but these actions have no clinical application. The mood elevation induced by cocaine reflects actions on dopamine or other amine mediated synaptic transmission in the CNS rather than a local anesthetic action on the membranes. Coming to the clinical uses, the local anesthetics are commonly used for minor surgical procedures, often in combination with vasoconstrictor agents such as epinephrine. Onset of action may be accelerated by the addition of sodium bicarbonate, which enhances the intracellular access of these weakly basic compounds. So there's a anesthetic called articaine. It has the fastest onset of action. Local anesthetics are also used in spinal anesthesia and to produce autonomic blockade in ischemic conditions. Slow epidural infusion at low concentrations has been used successfully for post-op analgesia in the same way as epidural opioid infusion. Repeated epidural injection in anesthetic doses may lead to tachyphylaxis, however. Intravenous local anesthetics may be used for reducing pain in the perioperative period, and oral and parenteral forms of local anesthetics are sometimes used adjunctively in neuropathic pain states. So, coming to the toxicity, the CNS effects, the important toxic effects of most local anesthetics are in the CNS. All local anesthetics are capable of producing a spectrum of central effects, including lightheadedness or sedation, restlessness, nystagmus, and tonic-clonic convulsions. Severe convulsions may be followed by coma with respiratory and cardiovascular depression. Coming to cardiovascular effects, with the exception of cocaine, all local anesthetics are vasodilators. Cocaine constricts, C for C. So, patients with pre-existing cardiovascular disease may develop heart block and other disturbances of cardiac electrical function at high plasma levels of local anesthetics. So, bupivacaine, a racemic mixture of two isomers, okay, may produce severe cardiovascular toxicity, including arrhythmias and hypotension. The S isomer, levobupivacaine, is less cardiotoxic. Okay, levobupivacaine is less cardiotoxic. So, cardiotoxicity has also been reported for ropivacaine when used for peripheral nerve block. The ability of cocaine to block norepinephrine reuptake at sympathetic neuroeffector junctions and the drug's vasoconstricting actions contributed to cardiovascular toxicity. When cocaine is used as a drug of abuse, its cardiovascular toxicity includes severe hypertension with cerebral hemorrhage, cardiac arrhythmias, and myocardial infarction. Coming to the other toxic effects, prilocaine is metabolized to products that include toluidine, orthotoluidine, an agent capable of converting hemoglobin to methemoglobin. Though tolerated in healthy persons, even moderate methemoglobinemia can cause decompensation in patients with cardiac or pulmonary disease. Okay, so the Ester type local anesthetics are metabolized to products that can cause antibody formation in some patients. Allergic responses to local anesthetics are rare and can usually be prevented by using an agent from the amide subclass. In high concentrations, local anesthetics may cause a neurotoxic action, local neurotoxic action, especially important in the spinal cord, that includes histological damage and permanent impairment of function. So, skill keeper, we can explain how hyperkalemia facilitates the cardiac toxicity of local anesthetics. We'll do that soon. So, coming to the treatment of toxicity, severe toxicity is treated symptomatically, so there is only symptomatic treatment. There are no antidotes. Convulsions are usually managed with intravenous diazepam or a short acting barbiturate such as thiopental. Hyperventilation with oxygen is helpful. Occasionally, a neuromuscular blocking drug may be used to control violent convulsive activity. The cardiovascular toxicity of bupivacaine overdose is difficult to treat and has caused fatalities in young adults. And intravenous administration of lipid, which is called lipid resuscitation, has been reported to be of benefit. So, coming to the skill keeper answer. So, sodium channel blockers bind more readily to open or inactivated sodium channels in both axons and cardiac cells. Okay, so local anesthetics, sodium channel blockers, they bind more readily to open or inactivated sodium channels. Excessive concentrations block conduction in the heart and precipitate arrhythmias. So hyperkalemia depolarizes the resting membrane potential. So more sodium channels are in the inactivated state and conduction block occurs at lower concentrations of the local anesthetic because it is already in the inactivated state, which binds more local anesthetic. Conversely, hypercalcemia tends to hyperpolarize the resting potential and reduces the block on sodium channels. So again, these are the things we have discussed, both enzymes, both amides and esters. Okay, so CYP 450, metabolism of the amides, and plasma esterases, metabolism of the esters. Okay, so amides block the sodium channels, esters, they also block the sodium channels, plus cocaine has intrinsic sympathomimetic actions. Okay, clinical applications we discussed about the analgesia thing, and then toxicities, almost all of them have CNS effects. Alright, so cocaine is the only vasoconstrictor, rest